Good afternoon, everyone. My name is Michael Schenkel. I'm the Director of Capacity Building with HealthHIV based in Washington, D.C. I would like to welcome you to our Fiscal Health from Systems Sustainability webinar series. Today's webinar will focus on maintenance of effort for Ryan White HIV/AIDS Program Part C recipients. Just as a little bit of background about HealthHIV, HealthHIV is a national nonprofit, again based in Washington, D.C. We have four main capacities offering capacity building, education and training to ASOs, CBOs, health centers, clinical providers, and other audiences, as well as a health services research and evaluation department, and provide advocacy through both our National Coalition for LGBT Health and Pause Healthy. Fiscal Health Systems Sustainability Program is a HRSA HAB-funded initiative providing education, training, and technical assistance programs to Ryan White recipients and subrecipients. We address the fiscal sustainability of Ryan White funded organizations by building their fiscal management capacity. And we do that through designing and implementing regional trainings and individualized technical assistance. At the conclusion of today's webinar, you may feel free to email us with questions, additional questions that you may have, or to request individualized technical assistance through our program. I'm now going to turn the platform over to Shana Linoff, who is our program coordinator with the Fiscal Health Systems to Sustainability Program. Shana?
All right, so just some logistics for this webinar. The slide deck is available in a PowerPoint version. In the bottom right-hand corner of your screen, you should see a folder icon, which is on the screen. You can download the PDF version of the PowerPoint there, or we can send it out later via email to everyone who attended. There's also a link to an evaluation for the webinar, which is very brief. It is just 10 questions long, and I will remind everyone about that at the end. You can just click on it from the folder icon there, and it will link out to another browser. So you can do that at the end, and we would very much appreciate your feedback after that. There's also a chat box that you should see in the bottom left hand side of your screen, and you can type in questions there. If you have anything that comes up during the presentation, we might interrupt Jana, our speaker today, but otherwise we can save questions until the end. And now I will introduce Jana, who will be the faculty for this presentation today. Jana Collins currently serves as the Research Protocol Manager for HIV programs at the Ryan White-funded Bluegrass Care Clinic at the University of Kentucky, where she has worked in various capacities since 2002. Jana has presented on various topics nationally, including budget development, data collection and management, sliding fee scales and caps on charges, program income, and managing multiple funding streams. In addition, she has served as a fiscal, administrative, and technical assistance consultant for HRSA, participating in diagnostic site visits for Ryan White grantees since 2008. So now I will turn it over to Jana.
Thank you. Well, thank you guys for being with us today, and I'm looking forward to this discussion about maintenance of effort. And like was said earlier, they may, if questions come in that are pertinent right to the point of discussion, they may interrupt me, and I'll try to answer questions like that as they come in. But then we'll try to have a question and answer session at the end to go over some of these. So today, the learning objectives, by the end of the session, the goal is that you'll have an understanding about the HRSA HAB maintenance of effort requirements for Part C recipients. I'm going to be speaking specifically about Part C today, kind of review some best practices for calculating and justifying maintenance of effort, and then I'm going to go through an example of maybe how you could calculate it. So I'm trying to, this is kind of a follow-up of a HRSA presentation on maintenance of effort, and so I want to present the requirements first, but I also want to kind of get to the nitty-gritty and nuts and bolts of what coming up with maintenance of effort looks like, so that you can go back to your fiscal folks, you can go back to your CFO and work on this as an organization. So I hope it's very practical in terms of coming up with the maintenance of effort for your organization. So in terms of the overview, we're just going to talk about the fundamentals. We're going to talk a little bit about the reporting requirements in terms of a compete application versus a non-compete application. Then talking about the methods of calculating maintenance of effort, some of the things that you'll want to be thinking about as an organization. And then, like I said, we'll do an example of an organization coming up with their maintenance of effort. So as a condition of eligibility for federal funding, recipients are required to maintain their financial contribution to the program at not less than a stated percentage. And that is the contribution for the period of time in the applicant's previous fiscal year. So we'll kind of get down a little more specific of that. But if you're applying for a grant in December and your fiscal year runs from June to July, if it was December of this year, then your fiscal year would be June 2015 through July 2016. So you're looking at how much your organization spent during that time period. So the statutory clauses are really intend to ensure that federal program funds are used to increase service levels in the program area, and these are the services specific to early intervention services, which we'll talk about in a minute. And these are the services provided to Ryan-White eligible patients, so low-income, uninsured, or underinsured clients. And really, the legislation requires this for organizations to maintain their expenditures for HIV-related activities at a level equal to the fiscal year preceding the fiscal year for which the applicant is applying. And really the goal is so that Ryan-White funds are just a piece of the puzzle. You know, most organizations that apply for Ryan-White funds have already been providing some services to the HIV population, and the goal for the grant funds is that not that they supplant or take the place of the funds that were used for those organizations, but really that they grow the program so that more services that are offered to more patients, that patients who maybe wouldn't receive services before, such as patients without insurance or that are underinsured and have huge out-of-pocket expenses, that they would be able to seek care and have great health outcomes. So the goal of the grant funding is to increase the HIV services and not just replace the services that programs are already offering. And I did want to mention that maintenance of effort is not a one-to-one matching requirement. So Part C and F, you may have a very low maintenance of effort when we go through the example and you think about what your organization does in terms of early intervention services outside of grant funds. It may be a low amount, and it also looks very different than Part A and B. That's why I wanted to mention this is specific to Ryan-White Part C. But it's not a one-for-one match. So if your organization receives $350,000, say, in Ryan-White funds, your maintenance of effort does not have to be $350,000. The expectation is not this one-for-one match. It's that your organization will just continue to contribute whatever it was contributing before Ryan-White funds were received or in the previous fiscal year, excuse me. And again, the goal is that Ryan-White funds are really only a portion of the funds supporting the organization's HIV services. So Ryan-White Part C has a maintenance of effort requirement, as does Ryan-White Part F for the dental programs, but Ryan-White Part D does not have a maintenance of effort requirement. And again, today we're talking specifically about Part C. So let's look at some of the reporting requirements. So when we do our competitive applications, we do have a signed assurance that maintenance of effort will be maintained. And there's a presentation of the baseline aggregate expenditures for the most recent fiscal year, and then typically a description of how that maintenance of effort was determined. What non-Ryan-White expenditures were funded by the organization's non-federal funds during the most recent fiscal year, and then a description of the methodologies calculating these expenditures. So when you do the competing application, you really want to have a good justification as how you came up with your number. And oftentimes that requires, a lot of calculations, as you'll see later on, really specific discussions with your fiscal department. Maintenance of effort is not really something that a program person could probably come up with on their own, because you're really looking at your organizational costs at a higher level and how that impacts the HIV program. What is the organization, whether it be staff, space, supplies, services, what is the organization already contributing to the HIV program, and how will that support continue once Ryan White funding is received? In the competing application, the recipient can include a brief narrative explaining any changes in the data set and any place where HIV-related expenditures have been reduced or changed. There is a chance, I think, when you have Ryan White funding that comes in, the organization may change how the funds are spent, but the requirement is that the funds are continued to be spent on the HIV EIS program. So I just wanted to put a little snippet of what the chart looks like that shows up in the competitive application. So it's a presentation of the actual dollar amount that was spent in terms of non-federal funds on EIAS activities proposed in the application. So I think that's one thing that I really want to drive home today, is when you are coming up with your maintenance of effort for your program, you really want to stick to the funds that go into the early intervention services cost. And that's your primary medical care for HIV patients, any treatment adherence, monitoring and education services, oral health, outpatient mental health services, outpatient substance abuse treatment, nutrition services, specialty and subspecialty services, medical case management, laboratory radiographic and other diagnostic testing, medical dental equipment and supplies, these clinical and diagnostic services that go into the HIV population. So when you're calculating your maintenance of effort, it's not necessarily every dollar that the organization may put into the HIV program. Some of that's going to be administration. You have higher level fiscal folks that are still touching the HIV program. But what you really want to look at in terms of maintenance of effort are those early intervention services that are detailed in your competing application and that are detailed in the policy notices and information that HealthHIV puts out. So you're going to report your actual expenditures for the previous fiscal year and then what you estimate your expenditures will be in the next year. And the requirement is that that number is at least equal on the right or more. So you're either spending at least what you spent prior to the application, but likely you're going to be spending more. And that's one example that I kind of want to walk through, is how your organizational support may change once Ryan White funding is received. So we'll kind of talk about both today. And then in the non-compete application, you're going to have the same chart that you're going to submit. And one is the actual prior fiscal year federal funding proposed in the competitive application. So what did you write in your competitive application in terms of how much non-federal funds were being expended by the organization for early intervention service activities? And then you're also going to present the actual, so that you can show how your organization has continued to support the early intervention services of your project. So let's kind of jump into the methodologies of calculating maintenance of effort. So again, we're looking at early intervention services. So that's counseling of individuals with respect to HIV disease, high-risk targeted HIV testing, referral and linkage to HIV care, and all of those other clinical and diagnostic services that patients need related to their HIV diagnosis. And these are the specific non-federal expenditures that have to be maintained. So you will report your baseline aggregate expenditures at the time of the application submission. So for example, if your FOA was due on December 12, 2016, and your fiscal year runs from July to June, then your fiscal year for that application, you would be reporting on your expenditures for EIAS services July 1st, 2015 through June 30th, 2016. So you would be looking at that previous fiscal year. And so that's important dialogue to have with your fiscal folks at your organization or your CFO or whoever will be in the know, I guess, enough to have this discussion with you, that it is specific to the fiscal year of your organization, it's specific to the HIV program, and even more specifically, it's specific to the early intervention services offered by your organization. So just when you're strategizing this, just remember that maintenance of effort has to be maintained from year to year. So if it's inflated at baseline, it has to continue to be inflated, and you have to continue to show that you are supporting the number that you reported initially. And there's also a recommendation, because income tends to change and fluctuate from year to year, that program income is not included in your maintenance of effort. But the goal is that this amount that you come up with is very realistic, it's justifiable, that you can pinpoint this staff member, this office space, this supply, getting as specific as possible so that this number is very real for your organization, it's very maintainable, and it's something that you will be able to continue while you are a Ryan White grantee. And when we were preparing for this call and some of our discussions, if you have submitted MOE information and numbers that you don't feel like is correct, maybe they're not specific to early intervention services, or maybe the work with the CFO didn't happen, and so that number isn't as specific as possible, you can work with your project officer to come up with a revised number that's accurate for your organization, that you can justify and pinpoint all those services. That way you have a realistic baseline that you're starting from. So the discussion was that you don't want this number high and inflated, like it's going to show how much you're contributing, unless that's what you're really contributing. You want this number to be very realistic and supportable in terms of numbers. And so those non-federal expenditures that we're talking about are state funds, private contributions, any kind of in-kind donations, fees, payments, reimbursements for the provision of specific services. You can count sliding fee scale payments by patients, health insurance reimbursements. What you want to keep out of this equation is federal funds. So if you are an organization, and I try to get into this in my example, if you're an organization that's, say, receiving CDC funding to offer some prevention services, you don't want to use CDC funds as part of your maintenance of effort. You're strictly looking at the non-federal funds that your organization is already expending on the HIV program for early intervention services. So in terms of calculating maintenance of effort, there's really not a specific formula to help you conduct an analysis of EIS for your expenditures. I think the beauty of Ryan White programs is they're all so very different. They're in federally qualified health centers, they're in universities, they're in nonprofit organizations, they're in very different places in different cities. And so it would be difficult to say, plug in these numbers here and this is your maintenance of effort. So the beauty in that is that you get to look specifically for your organization to show what they're doing. It's very specific to your program and how your program is supporting the HIV services that you're offering. You want to include a description of your methodology. How did your organization come up with this number? Are you looking at staff? Are you looking at space that's dedicated to the program? Are there certain supplies that the organization provides that Ryan White doesn't fund directly? And again, I can't kind of speak to this enough. It's really critical that you have conversations with your CFO or any fiscal staff when obtaining this information, because a lot of times this data is much bigger than the program. It's organizationally, how much each square foot costs, or how much different positions cost that support the program but aren't funded directly. So it's a bigger discussion that can happen just in program. So, as was mentioned earlier, I'm a recipient as well at the University of Kentucky, and when the maintenance of effort attachment came out in the first competing application, I kind of took two perspectives, and it was helpful for me, and I want to present it because hopefully it will be helpful for someone else. But I wanted to think about it from a new recipient standpoint and a recompeting standpoint. Before you were a Ryan White grantee, what does your program look like? And I think it's important to look back to that to say, what was the mission of your organization? How is it driven? What was it supporting in terms of of HIV services before Ryan White funding existed, because that will kind of lend you to the fact that there are a lot of things that go into the HIV program that Ryan White doesn't directly fund. So I thought back, before we got here, how were we seeing patients? How many days a week? Who was involved in it? And it kind of gave me a baseline. Even though it was 10 years past, it kind of gave me a baseline of what our organization's priority was in terms of seeing HIV programs for early intervention services. And then for the application, because we're looking at the previous fiscal year, you look at, well, what does it look like now? Now that we have funding, how do we look different? And what do we not pay for? You have to compare your specific line item budget that's submitted for Ryan White funds and say, what else goes into this program? Who else makes it run? Who else touches HIV patients for medical services that's not showing up on this line item budget? What space are we using? Are we paying for it? Is it a portion of, we may pay a little rent and utilities, but how big is that after hours coverage? You have to think of all of those pieces and parts that go into making this full comprehensive HIV care program and help you kind of determine what your maintenance of effort is and how that will be sustained as a Ryan White organization. So think about what early intervention services were provided and who it looked like. Were you providing to low-income patients? Were you providing to underinsured patients? Did you see underinsured or uninsured, or did you just see patients who had insurance? What did it look like before you received Ryan White grant funds? Who was being served? One thing that you really want to focus on with maintenance of effort is early intervention services and the percentage of patients who are Ryan White eligible. So we'll get into when I get into our example, there are some patients that are, maybe high income, high insured that aren't going to receive Ryan White eligible services. You may want to remove them from your equation so that you're as specific as possible to what the organization is serving in terms of Ryan White eligible patients and EIS services. So you want to look at what percentage of patients, Ryan White eligible patients, are being served, what EIS services are being provided, medical care, medical case management, treatment adherence counseling, what services are you providing? Also, I think it's important to think about what services are lacking or what are not sufficient, because that's really what your application is going to focus on. You're not going to focus on what you have. You're going to focus on what your organization needs to kind of move to that next level, to increase the services you offer, to increase the population that you're serving, and to ensure that all of these patients are receiving comprehensive HIV care and able to stay in care. What barriers are you removing? Think about who is serving HIV patients. Physicians, clinical support staff, case managers, front desk staff, who all are touching the HIV patients served by your organization, and what certain days are services provided. Sometimes programs start out and they're in a shared clinical space. It's only on specific days. They have very defined hours when they see patients. So you need to build that into your maintenance of effort. You don't want to declare that an entire office space is yours if you're only there 15%. So you want to get as specific as how often services are provided and where they're provided. Consider your staff. A lot of times there are organizational staff that are essential to the operations of the HIV program, but they're not directly funded by the Ryan White program. So someone is paying for them, and that's usually non-federal sources. So who are those people that are serving the HIV patients? And how will staff have to be expanded once Ryan White funding is received and services are increased to address a bigger patient population or just different services? You didn't have a mental health counselor on site and now you do because of Ryan White funding. Well, how does that change? Do they need an office? Do they need some kind of registration staff to help them manage a schedule? How will that change once funding is received? And again, this can be presented as FTE support, but you just want to be specific in terms of the percentage that's dedicated to the HIV program, to the EIS services, and the Ryan White eligible patients. So we'll look at that in an example here in a minute. Again, with office space, this probably, for me, this was the one that was the most discussion with our financial office, is looking at the specific office and clinical space that's dedicated to the HIV program, coming up with like an annual cost of space per square foot. I mean, we got that specific. This is how much in our organization we pay, per month. This is how much it costs to keep the lights on and all that good stuff. So coming up with a dollar amount there. and then again, decreasing it to the actual percentage used by the HIV Early Intervention Services Program. And then look at patient services offered. Again, you're looking at the services that are offered to uninsured, underinsured, and low-income HIV patients. So some of that will be medical services, case management services, translation, like the translation already exists for your organization, and so maybe Ryan White funds won't be paying for that, but that's a service that your organization is obviously funding. Financial counseling, after-hours coverage. Really look at all of the services that benefit your HIV population and how your organization is funding those services. And then again, I looked at this. We, of course, ended up taking it out, but you can look at the administrative and fiscal oversight, billing and transactional support. There are a lot of organizational costs that go into each individual program because a percentage of, even the CFO's time would be technically dedicated to your program, but that's not something you have to report in your maintenance of effort because, again, we're sticking directly to your early intervention services. And then supplies, office, educational, clinical, getting down to dollar amounts of how much they cost per visit, per patient, whatever your organization uses for forecasting, you would want to use for your HIV program. So we will dive into a case study, and hopefully this will kind of get us a good discussion started when we get down to the question and answer time. But we'll just say that Project HOPE is applying for Ryan White Part C funds for the first time. I'd like to start out with a new program, and then we'll talk about their competing application. So Project HOPE provides HIV testing and counseling 4 days per week. So in this example, 1 day equals 2 clinic sessions, 2 4-hour clinic sessions. So sometimes I use days, sometimes I use sessions, so I wanted to clarify that. But we'll say HIV testing and counseling is offered on site 4 days per week. It's CDC funded. They do approximately 3,000 HIV tests in the fiscal year 2016. So for their last fiscal year, they did 3,000 HIV tests. Right now, they're providing HIV medical care for 2 sessions per week. So that's about 20% of a person's time would be dedicated to the HIV program sessions. It's organizationally funded and focuses strictly on insured, underinsured, and low-income patients. Last year, there were 1,250 patient visits specific to the HIV program, which is 12% of Project HOPE's 10,583 visits in fiscal year 2016. So you can probably tell in this example that it gets very numbers heavy very fast. And so that's why you really want a fiscal person involved that can help you, and a data person really, because you want to look at number of visits for HIV program versus other. You want to look at HIV patients versus the full patient population. You really want to try to get as accurate of a picture as you can. So Project HOPE currently serves 250 HIV-positive patients, which is 15% of Project HOPE's total patient population, and 175 of those HIV patients, which is 70%, so this will be important in our example, are Ryan White eligible patients. So 30% of the patients being served right now would be considered high-income and insured patients, but 70% would be these low-income, underinsured, and uninsured. Well, I'm sorry, not uninsured because they weren't currently seen underinsured, but just underinsured patients. In their application, their hope is to expand HIV medical care to 4 days a week, which would be 8 sessions, and then they want to have medical case management on site 5 days per week. So that's what they're applying for in their application, versus what they have right now on site. So some expenses that I want to consider for Project HOPE is looking at salary and fringe that's currently dedicated to the EIS program, space, services, and supplies. There are other charges that you may think of once you get into this, but I just want to keep this kind of neat and clean for example purposes. So for pre-application, looking at service staff, right now clinic staff serve 2 sessions per week, so they're all organizationally non-federal funded. You have a physician, a nurse, a clinical services technician, and a front desk registration. So you have 4 people who are making this 2-session-a-week HIV program run. And then they also have HIV testing and counseling staff. So they have 2 testers and prevention counselors that are CDC funded. Those positions are, but again, that front desk registration staff is organizationally funded and is helping get those patients, in and out with the testers and the prevention counselors. So if you look at the staff salaries, what you'll do is look at each of these positions that are touching the HIV program. So again, we had a physician, we had a nurse, a clinical service tech, and a front desk staff. So I came up with, a example salary and fringe amount, and then you're going to reduce that down just to the HIV program effort. So that physician is seeing patients 2 sessions a week, which is 20% of their effort, which would be $31,500. So we're getting down to that specific. This is how much that person costs with salary and fringe. This is how much they're dedicating to the HIV-EIS program. This is how much it costs the HIV program. So I did that for the physician, nurse, and clinical services tech because they're serving patients 2 sessions a week. But for the front desk staff, I did 80% because the front desk staff person is there for the HIV testers as well. So hers was based on an 80% program effort versus 20% program effort for the other staff. Then you have that number. You have 81,648 as your staff time and effort that's dedicated to the HIV Early Intervention Services Program. Then what you want to do is narrow it down to the Ryan-White eligible patients. So if you remember in our example, 70% of those patients that were being seen by Project HOPE were Ryan-White eligible. So we'll take 70% of that number to get it down as specific as possible. So we'll say $57,150 are HIV program early intervention services offered to Ryan-White eligible patients. So it took several steps to get down to that number, but you want to start really big. Who are all these people? How much do they cost? And then how much are they serving HIV patients? And how much is dedicated to that Ryan-White eligible patient? So for their salary and fringe, we've got that in as $57,154. Now, space will get difficult. You may have to pull out, we had to pull out charts from the architects, but looking at how much square feet of clinical space and office space you have, and then getting down specific as, how much does each square foot cost, and how many sessions per week or hours per week is it being used by the HIV program. So we have a clinical space that's 900 square feet that's being used 2 sessions per week. And then we have 2 private offices that are 128 square feet each that are being used 5 days a week by the testers and counselors, which again is not, those positions are CDC funded, but their space is not. So I'm looking at, you take that clinical space and you look at how much it costs for the full year. I did $25 per square foot per year just for ease of numbers. And then you're going to look at the percentage used by the HIV program. So we've gotten it down to about $7,700. And again, then you want to take that 70% number of Ryan-White eligible patients. Again, trying to get that down to as specific as possible. So the space for the HIV program for early intervention services was determined to be $5,390. So we're filling in our little chart. And each step in the discussion gives you the justification and narrative for your attachment for your competitive application. So you can go back and pinpoint, this is exactly how we came up with it. These people are serving HIV patients. This is how much we cost. This is the number we came up with. This is exactly how much clinical space is being used. This is how much it costs. And this is what we're dedicating to our maintenance of effort. So some years it may not change a lot. Once you're funded and you have pretty stable staff, this maintenance of effort number may not change a whole lot. I think it changes from pre-application to post-application pretty rapidly. It could, but year from year, this number won't change significantly. You may have a 3% increase for staff, or cost of operations may increase a little each year, but overall, some of this maintenance of effort will stay pretty constant from year to year once it's determined. So again, looking at the services that are being offered, pre-application, we've got the testers and counselors. We have the HIV medical care that's being offered 2 sessions a week. And then let's say I'm going to throw translation services in there that's being provided during a medical appointment. And after-hours coverage for physicians on call. So those are 2 organizationally funded services that aren't going to be supported by the Ryan-White grant. They're not applying for it. So those could be built into the maintenance of effort as well. So again, you're looking at getting with the CFO and finding out how much the organization costs for each of these services. So for translation services, we're going to say in the previous fiscal year it was $47,880, and after-hours coverage cost the organization $97,000. So when comparing the HIV program to the full organization, that was 15% of what the full organization does. So that's why I changed this percentage of the HIV program, because now we're looking specifically at the whole organization versus just the HIV percentage. And then the cost of the total HIV program would be the $33,828. And again, you're making a reduction of 70%. Looks like my 33,000 is wrong there. I think I messed up my adding. Sorry about that. So now you continue to build your case. You have your salary and fringe, you have your space, your services, and then you can look at supplies. You can look at office supplies for the clinic. If you have paper charts, you're looking at paper for the charts. You could do letters to patients, whatever office supplies go into making just the clinic work, not administration. Clinical supplies, what is the cost for the organization per patient visit? I just estimated it to be $4.35. And then you can look at educational supplies, whatever supplies the organization is funding for your HIV program. And again, then you'll get down to the specifics. How much is costing the organization for the HIV program, and then the percentage of Ryan White eligible patients. So the bottom line is we've done this math, we've talked to our CFO, and we've decided that our maintenance of effort is $82,061. So that's what we're going to report as our previous fiscal year's expenditures as $82,061. And that is the amount that we're saying we will maintain for the next fiscal year when we receive Ryan White funds. And again, your narrative can describe exactly what you did, what staff were figured into this equation, what space, what services, and supplies. So then when you get to recompete, then you're looking at how did the organization support maybe change when the HIV program funding was received? What changed from one year to the next when funding was received? Now who is being served? How has the population changed? Now you have some uninsured patients. Maybe you have some more underinsured patients and low-income patients that you were able to encourage to attend your program because you had services now you could offer them that you couldn't offer them before. Who is serving the HIV patients? Do you have more physicians or more physician time, more clinical support staff, new disciplines of providers? Did you add medical case managers? Did you add mental health specialists? And how are services provided? Did you expand your hours? Do you need more exam rooms? Is there now a dedicated program space since the HIV program is seeing patients more? Are you not sharing with another clinic? And then what services are offered? Do you have increased medical care, more medical case managers, more mental health therapists, adherence counseling? What does it look like now? And so I wanted to do kind of a case study, too, for Project HOPE after they've been funded for a year. So now they have clinical sessions 4 days a week, so 8 sessions for 80%. Their population's changed because now instead of having 70% of their patients Ryan White eligible, they've added several uninsured and underinsured patients, and so 85% of the HIV population is now Ryan White eligible. They have a physician that's there full-time that's funded by Ryan White, and 3 medical case managers that are funded by Ryan White, as well as those 2 CDC testers. But organizationally, they still have the nurse, the clinical service tech, and the front desk registration. But now you want to look at how that's changed. The nurse was 20% for the HIV program, but now they're 80% for the HIV program. And the clinical service tech, same story. They were there 2 sessions a week, but now they're there for 8 sessions a week. So more of their salary and their time is dedicated to the HIV EIS program. And their front desk staff is now there 100%. So now the total cost is $125,748, and when you reduce it down to your Ryan White population, well, now it's 85% and not 70% because your population has changed. So when you look at pre-application, maybe the organization was contributing $57,000 and now it's contributing $106,000. So it could change as your services expand. Your support from your organization may change as well. It may not, but I'm just trying to give you an example of things you need to think about when you're talking with your financial program. again, when you look at space, where we were looking at space as 20% of the HIV program, well, now you're there a lot more. You have 8 clinic sessions, and so you're going to want to look at a larger percentage of that clinic space is now dedicated to the HIV program. You need more offices. You have more full-time. You have your 3 new medical case management staff, so now you have 3 private offices. So your space is also increasing. So I took our same example of our clinic space. They stayed there, but now instead of using 20% of the time, they're using it 80% of the time. And so when you look at their total program cost, it's up to $26,000, and because their Ryan White eligible population is larger, now it's $22,000. So space increased from $5,390 pre-application to $22,100 post-application. So not every program won't be that dramatic, but I think it's important to look at how the MOE changes pre-funding versus post-funding. How does your organizational support expand as your program grows, as you add different components of the HIV program, and then you can use your narrative to describe that. Who is the staff that the organization is supporting for your program? What space is dedicated? What services is dedicated? And and what supplies? And there are other program costs that the organization is likely contributing, but I just wanted to use those as an example to help you. So it's pretty nitty-gritty discussion, and you really need to have kind of a good game plan when you go meet with your CFO, because this might be out of the ordinary in terms of what they do for grant programs, but it might be worth sitting down with your medical director, your program director, some of your staff, and kind of brainstorming all the different pieces and parts that go into the HIV program, so you can give the CFO some direction, like, this is what our HIV program does, these are all the people that are supporting it, and kind of help guide them to come up with some numbers for you to determine the maintenance of effort. So that's it in terms of my slides, and then I'll try my best at questions.
All right, thank you, Jana. We do have several questions in the chat box that you all have been typing in throughout the webinar. So I'll just go through some of these. Some of them overlap. We actually got a couple questions, Jana, that ask if 340B is considered federal funding. So if you want to start there.
Oh gosh, I don't think I want to start there. Next question. I mean, it's that. Michael, do you want to say anything about that? I mean, they said not to program income to not be figured into that, so I don't know how 340B figures in.
Yes, we're going to just, before we answer that question, we're just going to vet that question with HRSA, HAB, and send that out to folks who are on the webinar. I know that there are some different calculations that happen with MOE versus considering program income, considering 340B to be part of this calculation, but I just want to verify that just to not give you any wrong information.
Thank you.
Okay. And yeah, we can send, if there are any other questions that we don't get to today, we can send them out to all of the participants after, or you can email us and we can try to address them directly. All right. There's a question from Michelle that says, can MOE be larger than the grant award?
Well, I would answer that as yes. My organization, the MOE that I came up with was larger than our grant award. It really depends on how big your program is and what your organization is funding. When we initially applied for, I don't want to get too personal, but when we initially applied for HIV program funding, it was because our organization said we couldn't continue on because we had so many HIV patients coming that were uninsured or underinsured, and we just couldn't fiscally continue it. So they have always dedicated a lot of funding, space, personnel to our program, but Ryan White really changed what we were able to do because we were either going to have to stop serving patients or come up with another plan. And so, yes, I think maintenance of effort can be more than your grant funding if that's what's accurate for your early intervention services program and what your organization is supporting.
All right, and just a follow-up question from Michelle, would state funds include Part B?
I don't know. I don't think you would include Part B funds in that. It would be, because that's still federal funds that are, if the Ryan-White program, I try to think if the Ryan-White program did not exist, would this exist? And so if Ryan-White B is coming from the state, it's still Ryan-White B dollars that would not exist if Ryan-White didn't exist. So no, I wouldn't think that would count.
Okay. And our next question is, do you report only for Part C or your program as a whole?
That's a good question. So it is a requirement of Part C, but I think you're looking at specific to the HIV early intervention services. So it really depends on how your organization delivers those services. And I guess if you're dually or triply funded, if you want to ferret that out, you can. If a certain percentage of your patients are D or B, and you want to take those out, you could do that just like we did the Ryan-White eligible patients. It really depends on how your organization is funding that. But the point is what your organization is supporting for HIV early intervention services.
Okay. Next question, are expenses for support services and CQM excluded from the MOE?
So that's a good question. My understanding is yes, it's early intervention services, and when I put the translator in there, I kind of went back and forth of whether I should or not, because I think that probably is a support service. But the most recent language that was in the non-competitive application was looking specifically at early intervention services.
Okay. Our next question is, could you talk about whether MOE is based on income or expenses?
So MOE would be based strictly on expenditures, what your organization is spending on the HIV program. So it wouldn't be, expenditures are related to income because you have to have the income in to do the expenditures, but you're specifically looking at the dollar amounts expended during that previous fiscal year on the early intervention services for the HIV program.
All right. Next question is, do you have recommendations for determining HIV program effort for individuals?
So, okay, I guess, you would do it you could do it a couple different ways. It would be similar to how you would be determining time and effort. If the person is seeing a population of patients, you could take a percentage of how many are HIV patients versus the full population. You can be dedicated to hours to the program. I guess it would be specific to how you would determine their time and effort if you were doing anything else. I'm not sure if that answered the question. I may not understand.
And Jana, it's Michael, just adding to that, I do want to indicate that we do have a time and effort webinar recording that is available on the Target Center for individuals to access if they want to know more about how to determine time and effort and track time and effort.
All right, and the next question is, in your example, I think this was from about halfway through the slides, was the 70% Ryan-White eligible constant across all services? And he says, for example, were the testing patients the same as medical?
That's a good question. I just did kind of a blanket statement for the HIV program. So I took the patients that they were seeing and looking at the federal poverty level and insurance status of the patients that we're seeing. If you had the data on the testing patients, then you could probably do that separately. I just did it as a blanket statement.
Okay. All right, and our next question is CDC counseling and testing funding that comes through the state to the grantee regarded as federal funds? Oh, did I ask this? Regarded as federal funds, or are these regarded as non-federal funds?
So again, I think you still have to consider the source of funds. You'd ask a similar question about Ryan White Part B. I mean, I think that still those services, even though the CDC funds are passing through the state, they're going to be reported back to the CDC as services funded by the CDC. So I would still consider that federal funds because it's flowing to the program through the state, but it's still CDC dollars.
Okay. All right, one of our last questions is, patients that are insured, are they included in calculation of methodology?
The insured patients, is that what you said?
Right, yeah.
So I think they can be if they're considered underinsured. So the Ryan White eligible kind of blanket statement is if the patient is low income, uninsured, or underinsured. And typically underinsured is if they have deductibles and copays out of pocket that are kind of unsustainable without assistance. So I believe insured patients you would be kind of cross-referencing federal poverty level and their insurance status. So that's when kind of low income would come into play.
Okay. Next is, why can't indirect costs be included in MOE?
Why can't indirect costs? I don't know that I don't know that I can answer that question wholly. Michael, is that another question that we can ask?
Yeah, we can refer that back to HealthHIV just for clarity on that, why that is not included. Right.
Yeah.
All right. So we can move on to the next. What remedies are available to Part C recipients when there are potential decreases to the maintenance of effort due to vacancy savings?
Okay, repeat that again, I'm sorry.
What remedies are available to Part C recipients when there are potential decreases to the maintenance of effort due to vacancy savings?
Again, I think that's a discussion that you'd want to have with your project officer. I mean, if you're to me, I'm not a project officer, so this is Jana answering the question. I think if you're doing your due diligence work and coming up with that numbers, I mean, vacancies are going to happen, and if you can, I mean, if your organization can refunnel those monies, maybe that's possible, but I think that's a discussion that you need to have with your project officer. If there's lots of vacancies for long periods of time, that's obviously going to impact what the program's able to do in terms of HIV care, and that may be a bigger issue that needs to be looked at. So I think, to me, that's going to be a case-by-case discussion with your project officer on what your organization's going through and what you're able to maintain.
Okay.
I don't know if Michael has anything to add to that, but that would be my take, would be having a discussion with your project officer about each case.
Yep, he's nodding.
Sorry.
All right, our next question is, for non-compete that we have due next month, we use the MOE that we used, do we use the MOE that we used in the MOE last year, or do we recalculate our MOE for the past fiscal year?
So I think that I just did mine because it was due today, right? I submitted it last Friday. So I think the instructions are pretty specific. I think you submit the amount that you said in your competing that you anticipated, and then you submit what actually happened during the fiscal year. And actually, based on some of the research I was doing, what I had presented previously to my project officer included some things that weren't EIS. So I actually put, the old amount and the actual amount based on the wrong calculation, and then added an asterisk and said, but I actually calculated this incorrectly and added the correct amount in both places. So I think the instructions are pretty specific, that you present what you forecasted and then what the actual.
All right. All right, our next question is, I'm particularly interested in determining effort for non-clinical employees. Would this be included in the time and effort webinar? And
the answer to that is yes, it would be included in the time and effort webinar. But we are happy to work with any recipient or subrecipient in helping them navigate time and effort?
Okay. Our next question is, on the second sample, the MOE increased due to increase of population and personnel related indirect or indirectly to the grant. But that doesn't mean your agency can keep that amount of money if the grant is not there. How does the agency guarantee MOE based on the calculation presented on the sample?
In terms of the next year, is that what, I'm not understanding that question. I'm sorry. Do you mind to repeat it?
Sure, I can repeat it. On the second sample, the MOE increased due to increase of population and personnel related indirect or indirectly to the grant. But that doesn't mean your agency can keep that amount of money if the grant is not there. How does the agency guarantee MOE based on the calculations presented on the sample?
Well, the second example was looking at a fiscal year after the fact. I mean, what I was trying to demonstrate was that if you received grant funding and now this is, I mean, this has to be the discussion before the application goes in. If you're saying you're going to add 4 staff members, then someone in the organization usually has to sign off and say, this is where we're going to put those 4 people. So there has to be some support before even the application goes out that the organization is going to be able to support the costs that are coming because the grant came. So I was just trying to present, you know, the grant came and then in the previous fiscal year, this is how the organization supported those changes. Does that make sense?
All right, sorry, I had accidentally muted myself. All right, I was just reading off the question. I'm not sure exactly how it was to be interpreted, but we can, if there are any more questions on that, we can follow up by email also. And I will just move on to the next question. Is it okay to have a $0 MOE if the only funding you receive is Part B and C?
So I would think no. I just because, and maybe this will probably be a discussion that you need to have with your project officer. I'm just trying to think if I've ever seen a scenario where an organization has no other funding contributing to the programming because of like the administrative caps and things like that. I don't think I've ever seen a program that's fully supported by Ryan White funding and has no other funding sources. So I have a hard time coming up with an example, and maybe it's totally possible and it exists, but that would probably be a discussion you need to have with your project officer on what your program, you know, what your specific program looks like and how it's totally supported. I can't really answer that question without, I think, looking at it, but I just can't right now between site visits and organizations I've worked with, I cannot think of one example where that would exist. Sorry.
Okay. Well, thank you, Jana. We are just about out of time, and I see that we still do have a few more questions that we haven't gotten to. So we can go through the rest of these and address them and email people individually if they still have anything specific that they'd like to talk about. Otherwise, if you have any other questions that we haven't answered or gotten to yet, our contact information for me and Michael is on the screen here. We can also send questions over to Jana if we're not able to answer them. But for now, we can, if you hadn't already gotten to the PDF of the slides, which is in the folder icon on the bottom right-hand of the screen, you can download them there. There's also a link to a evaluation survey that I put in there, and we would very much appreciate if you're able to fill that out. It's very brief. It's only 10 questions. And if you have any other questions, you can either type them into the chat box now and we'll make a note of them, or you can email us after you've logged off. So I just want to say thank you again to Jana, and thank you all for participating.
Thank you.